Welcome all. I, Dr. Linesh Yawalkar from Adolescent Health Academy, Nagpur, welcome you and extend my greetings to all the people who are watching this video and advocating good mental health for adolescents. World Suicide Prevention Day is an awareness day observed on 10 September every year from 2003. On this occasion, Adolescent Health Academy, Nagpur, in association with Maharashtra Adolescent Health Academy, has organized this panel discussion to spread awareness about suicide and its prevention. Suicide is an important cause of death from adolescence onward. Children below age of adolescence generally do not commit suicide. So what happens during adolescence? What changes happen in adolescence that make them prone to suicide? They develop the vision to look forward and pursue hope. They develop the vision to look around and gather help. The feeling of identity and worth develop during this adolescence. But stress multiplies. The understanding of responsibility and the independence to take our own decision grows. If any problem appears in all these things, the scenario of hopelessness, helplessness, worthlessness may come into picture. Let us learn it in detail and become resilient. Today, we have Dr. R.N. Sharma sir from Central AHA India to bless us. I request Dr. R.N. Sharma sir to give his blessings. Sir, unmute yourself.
Very good evening, dear all, and I congratulate Adolescent Health Academy Nagpur and AHA Maharashtra and all stalwart of IAP and AHA for arranging this webinar on this auspicious day. And I wish all the best. Hope it will definitely create awareness regarding the suicidal prevention. The incidence of, as you all aware, is increasing in our adolescents. So I wish all the best and happy learning. Thank you. Thank you very much, sir.
Thank you, Sharma sir. Thank you very much. Now I invite Dr. Ram Bharat, who is a pediatrician from Chandrapur and an adolescent stakeholder, to conduct this panel discussion. We have a panel of eminent speakers and faculties today. Let me introduce them. Our main faculty today is Dr. Sushil Gawande sir. He is a senior psychiatrist from City, Nagpur, a professor in Department of Psychiatry in Lata Mangeshkar Hospital and NKP Salve Medical College, Nagpur. He is a good orator and effective counselor. Our another speaker is Dr. R.G. Patil sir. He is Joint Secretary of Central AHA Nagpur, Senior Pediatrician and Adolescent Counselor from Nagpur. Then we have Dr. Nishikant Kotwal sir, Chairperson of Maharashtra AHA, Senior Pediatrician and Director of Colors Hospital, Nagpur. Then we have Dr. Kamlakar Deoghare sir, ex-chairperson of AHA Nagpur, Senior Pediatrician, Adolescent Counselor, a retired professor from Advocate Dr. Manohar Institute of DMLT College, Nagpur. We have Dr. Abhijit Bhardwaj, Executive Board Member, Maharashtra AHA, Senior Pediatrician, Psychologist and Director of Anurag Children Hospital, Wadi, Nagpur. We have Dr. Ram Bharat is our moderator today. He is an energetic person, yet a senior pediatrician and neonatologist from Chandrapur. Also an adolescent counselor with interest in varied fields of health. We have Dr. Dinesh Saroj, a developmental pediatrician from Nagpur, an honorary secretary of AHA Nagpur 2024. Now I invite Dr. Ram Bharat to conduct this panel discussion. Dr. Ram Bharat, please.
Thank you, Dr. Linesh sir, and thank you, Dr. R.N. Sharma sir, for your blessings. Warm wishes on this pleasant monsoon morning on this very sensitive topic of suicide. As we all are aware, suicide is an intentional act of ending own life. And we all are aware it's a crime. because we don't have any right to take our life because we haven't created it. So today, with the theme of changing the narrative on suicide, we have we have organized this panel discussion on resilient youngster in association with Adolescent Health Academy Maharashtra. Resilience is an ability to withstand, recover, and adapt in the face of adversity. We all are aware we are talking this resilience in context of suicide. Suicide is third leading cause of mortality in adolescent in India after road traffic accidents and interpersonal violences. So, in spite of professional and festival commitments, all dignitaries have come for this panel discussion, and they have given their precious time. So let's start with panel discussion. So first question to Dr. R.G. Patil, sir. Respected sir, you are practicing adolescent medicine since more than 3 decades. Sir, I want to ask you, what is magnitude of this problem? What is prevalence of suicides in India as well as worldwide?
Yeah, I'm audible, Ram?
Yes, sir. Yes, sir.
Okay. Good morning. First of all, I would like to thank the chairperson of the HA, Dr. Linesh, and secretary, Dr. Dinesh, and the coordinator of today's program, Dr. Ram Bharat, and all my best wishes to all of my esteemed members. And this is very important topic, prevention of suicide. And the topic is the theme of this year is changing the narrative of the suicide is very appropriate. As all of you know, suicides, they are very common in adolescents, and most common age is between the 15 to 27 years. And there are multifaceted reasons, might be some physical problem, mental problem, or some social problem or cultural problem. So it is most important is that most of the suicide they occur due to the mental health problem. That is very important. My panelists, my esteemed faculties, they will explain better than me. So the today's scenario in as a global worldwide suicide rate is 7 lakhs in the global it's a worldwide, and out of which this 7 lakhs it is a 164,033 uh, in Indian scenario, that is a youth suicide, and it's constable to 23.4% according to the National Crime Records Bureau 2021. Uh, and we have seen the suicide rate in adolescent that is more common during the this COVID pandemic. Why this was common in COVID pandemic? Because of the most of the adolescents, they were within the four walls. So there is a lot of depression, suicide. There is a lot of communication, no academic activity, no outdoor games. So this what you call the suicide rate that was more seen in during the pandemic period, and it has been seen there is a what you call changing trade. So in females, the suicide rate is as much common as compared to male adolescents. Secondly, the what you called in India today, about 35 suicides per day is occurring in India. So this is a common scenario in the global as well as India. So how to prevent this suicide, how to prevent or how to create awareness. So this can be explained by my co-panelist. Thank you, Dr. Ram. And second is I want to just explain that there are other ways of how suicide is, how they are attempting. So most of the adolescents they choose the high height buildings to commit the suicides, then water bodies, then some poisonings, substance abuse, then pesticide, they are taking pesticides, firearms they are using. And it has been seen in also today the copycat suicide. Most of the what you call the celebrities, they the celebrity they commit suicide, and what today's youth they take the example, they imitate their how they are committing suicide. So these are the copycat suicides. and this is the scenario in the global as well as Indian scenario.
Thank you, sir. The figures are really alarming. Now, I want to ask Dr. Sushil Gawande, who is a psychiatrist and dealing with people of all age groups. Dr. Sushil, I want to know why adolescents are more prone for suicide than other age groups.
Uh, Thank you, Ram. And again, thank you so much, Linesh sir, Ram sir, and Indian Academy of Adolescence chapter for giving this opportunity. To be very, very brief on this topic, putting some lines to the narration given by Patil sir, if we see the current data of the press release of 29th August 2024, National Crime Record Bureau, there is 4% rise in the suicide among students. So now it's not a former suicide which is occupying the top post, it's students suicide which is occupying the top post. Second, Maharashtra is a leading state. So Maharashtra and the Tamil Nadu. So that is something very, very alarming for all of us. It's not that suicide is only there in youngsters, it is there in all ages. Okay, but now the trend is changing. Earlier, it used to be in the middle age and the late age, and the suicide was less heard among adolescents. Then changes started coming, and there were more suicide attempts among adolescents, but completed suicides were more in middle age and the elderly age group. And now the trend is changing that even a completed suicides are more among the youngsters, and it is still there in the middle age, elderly age, but this trend among the youngsters is increasing. And there is very difficult to tell the one reason for this, but see why suicide is not common among children, because they are not able to think about the failure and how to deal with it, right? Or just end the life to end the misery. That concept will not come in the mind of the children. But by the time they are in the adolescence, that cognitive changes started coming. So the first thought that I should end my life may not come even before 12 years of age. So after that, a cognitive thinking comes. So now with the evolution, the adolescence, the thinking capacity of the adolescence is coming below even 14 years to 13 years to 13 years to 14 years. So now the adolescents of that particular age group are more able to think about the outcomes of their competitive worlds. So when we were adolescents, we were not that cognitively developed to think about the matters as compared to ourselves, the today's generation. So what we were able to think at the 18 years of age, they are very well able to think about the same topic at the age of 14 years. So now with the more competition and the more academic pressures, all this is making youngsters prone for the suicide. So there are biological factors, psychological factor, and the social factors. But among that, I would say the psychological factors, more of a competitive environment in the society, and a lot of academic pressure, and then they are getting driven by the digitalization. Different sources are there. All these are coming together. So I would say psychological factors are taking a lot. Psychological and social factors are coming upfront. So among middle-aged people, biological factors like the depression and all those illnesses are more common. But among the adolescent, the psychological and the social factors, and among that also, the more competitive environment which we have created for our children, that is creating a problem for them, because a child in a 11th standard or a 12th standard, if he thinks that if I don't get admission through the NEET or through the JEE, what would be my future? So ultimately, if not, they think that it's a doom, okay, it's a blank future, and that academic is taking a toll on their mental health. So I would say psychological factors during the adolescence are more contributory.
Thank you, Dr. Sushil. Can we summarize it like this? They are emotionally more labile, but they have poor control. Means it's just like a vehicle with high octane engine but poor brake, right?
Absolutely.
Yeah. Thank you, Dr. Sushil. So next question to Dr. Abhijit sir. Sir, what are predisposing factors for suicide?
Yes. As stated by Dr. Sushil, adolescent suicide is a very complex issue and various predisposing factors increase the risk. The first important thing is the mental health disorders. Those who are having some mental health disorders like depression, anxiety disorder, substance abuse, or previous suicide attempt. These are the four things which are known to predispose for suicide. Out of this, as we know, depression can lead to feelings of hopelessness and worthlessness. And this is the first indication that a person can commit suicide. Then, as stated by Sir, psychological and environmental factors, they are very common. And it has often been found that there is family history of suicide or mental illness, and genetic predisposition should never be ignored. Trauma or psychological abuse, as Sir has told, and even physical abuse or sexual abuse. This is also one of the factor which can contribute to suicidal ideation. Then in this era of net age, we can say bullying and cyberbullying. This is also becoming is known to exacerbate the feelings of worthlessness. Then there are various relationship issues. As we know, adolescence is a period of romantic relationships mainly. And then there can be problems, there can be breakups, and this can also lead to predispose them to suicidal tendencies. As Sir has rightly said, academic pressure. Then one more factor is loss of grief. The death of a loved one or a significant loss such as breakup, this can also trigger suicidal thoughts. Then chronic illness or disability, this can also lead to suicidal ideation. Then among the social and cultural influences, lack of support systems. Adolescents who feel isolated from family or friends may be at greater risk. Exposure to suicide in the media, peer, or community can lead to imitation, as Patil sir has rightly said, copycat activities. Then there are certain cultural or religious influences. They can exacerbate the feelings of guilt and shame. And one more important finding has been found to be access to means. Wherever there is access to firearms, medications, or other means, or where there are the lethal means, increases the likelihood of a fatal suicidal attempt. So all these factors often interact with each other, creating a complex network of risk that can be difficult to manage for an adolescent, and he may commit suicide. Thank you.
Thank you, sir. Thank you for explaining all those points in a very comprehensive way. So next question to Dr. Sushil. This suicide doesn't happen all of a sudden. There must be some change in behavior. There must be some change in that adolescent before suicide. So will you please explain us the term, what is suicidal behavior?
Yes, I would add one more term to that, that is they are called as depressive equivalents. So adults would convey that they are feeling persistently sad. Adults would convey that they have a loss of interest in everything and they are getting a thoughts of suicide. But the adolescents and the youngster may not convey this, but there would be a depressive equivalence. I would say in almost all adolescents who would commit suicide, there would be depressive equivalence prior to that, few months prior to that. So declining attendance in the classes, okay, declining academic performance, decline in their social relationship. They are not playing as much as before, and they are not as cheerful as before. They are losing interest in eating. Means earlier they used to demand कि मुझे ये dish चाहिए, वो dish चाहिए. They have start reducing those demands. Then irritability, intense irritability on a small matters, and very important, they would try to seclude themselves. Means they would start spending time alone as compared to their previous nature. So this sudden change in a nature, they are called as depressive equivalents among the children. So, and this childhood depression is common. It has no age barrier. This can be seen even in a 6-year-old child or a 10-year-old child. Only the symptoms will be different. So these are called as a depressive equivalents. If there is sudden change in the nature of a child, nature of the adolescents, based on all the factors I mentioned, they should be taken very seriously. They are depressive equivalents.
Thank you, Dr. Sushil. This is really an eye-opener because many times we think these are normal changes of adolescent as per age, as per hormonal changes, as per behavior, but these have to be taken seriously.
Yes.
So yes. So next question to Dr. Abhijit sir. Sir, is there any association between neurotransmitters in brain and suicidal tendencies?
Yes, this has been an area which has been researched widely, and the association between the neurochemicals in the brain and suicidal tendencies is a well-researched area. Imbalances in certain neurotransmitters can contribute to suicidal ideation and behavior. The neurochemicals which are implicated are serotonin. As we know, serotonin is a neurotransmitter that regulates the mood, emotion, and impulsivity. Low levels of serotonin are strongly associated with depression, impulsivity, aggression, and suicidal behavior. Then this next is dopamine. Dopamine is involved in regulating the pleasure, reward, and motivation. So as we know, uh, as there is increase in dopamine, we feel energetic and everything, all this. So it is also linked to executive functions such as decision making and emotional regulation. So loss of emotional regulation, this can also lead to suicide ideation. Then another thing is that the various neurochemicals like noradrenaline, GABA, glutamate, and cortisol, these have also been implicated and found some relationship with the suicidal behavior. I think Dr. Sushil will throw more light during the treatment part. As we know,
Yes.
these
Yes.
neurochemicals and how they can be managed by various drugs, this will be taken by Dr. Sushil sir.
Yes. Thank you, sir.
Yes,
Thank you.
thank you.
So this next is a very important question for Dr. Sushil. We know the incidence of suicide in normal adolescent is only 1 to 2%. But if there are associated mental health disorders, it can increase up to 45 to 50%. So
Oh,
what are those mental health disorders which increases the chances of suicide in adolescent? And also I want to ask Dr. Sushil, if an adolescent has committed suicide attempt before, are there any chances of recurrence of doing the same again, and how to help that individual? Dr.
yes,
Sushil.
yes. Yes. In connection with the Abhijit sir's narrative, uh, in most of the studies, whoever attempts suicide, if we collect the CSF and check for 5-HIAA, that is 5-hydroxyindole acetic acid, that's a metabolite of the serotonin. You would find in almost all, I would say, those who attempt a serious type of the suicides, okay, you will find a decline, a reduction in the metabolite, that's 5-hydroxyindole acetic acid, which clearly indicates that there is a serotonin drop in the brain at that moment of a time. Now, second, I would like to clarify. Initially, we used to talk about endogenous depression and the exogenous depression, right? And people used to think that endogenous depression means something which happens in some neurotransmitter changes happens inside the brain, and that leads to depression, that is endogenous. And when some external factors are responsible, that is exogenous. But now this classification is no more valid. Depression is just depression. There is no exogenous or endogenous. It means what? If you are trying to commit suicide, irrespective of any cause, means psychosocial cause, biological cause, the same changes are observed in the brain. So even after failure in 12th standard examination, if I am attempting suicide, the changes inside the brain would be same as compared to any other middle-aged lady out of a depression she is trying to come. So now there is no more distinction between this. There is depression means a depression. Neurochemical changes are very, very common. 95%, Dr. Ram, 95% of the suicide, they are because of the mental illnesses. And that is the reason in Mental Health Care Act 2017, section Indian Penal Code 309 was there for the suicide. It is now decriminalized. Earlier, committing suicide used to be a crime, used to be an offense. And there was a provision for arrest also. Now it is completely decriminalized. It means what? We have all developed the understanding that it is a product of severe mental distress. So they will not require a jail, they would require a treatment. That's the reason it is now decriminalized. The section IPC 309 is no more existent. So 95% are because of the mental illnesses, and leading among that is a depression. So in a childhood depression, even an adolescent depression is now increasing. And if you find out some of the countries in South Africa, there is one country called a Lesotho. This Lesotho country is near South Africa. You won't believe the suicide rate is 87.5 per 1 lakh. In India, with the 2019 NCRB data, it is 10.4. In that country, it is 87. 1 lakh के पीछे 87 people they are dying because of this. Cause is depression. Those who are suffering from the depression, around 40-45% they attempt suicide, and out of those, around 15% they succeed in dying with the suicide. Second reason after depression is a bipolar disorder. In a bipolar disorder, there are two phases, manic phases and a depressive phases. Now, many adolescents, they commit suicide during the depressive phases of the bipolar disorder. Third important illness is a schizophrenia. So this is now it is called as early onset schizophrenia, EOS. So schizophrenia earlier used to be taken as a disease between 15 to 35. Now it is no more like that. Even in earlier ages, it is there. So now with the schizophrenia also, people, youngsters, they can commit suicide. But before going into depth, we have to simply understand two terminology. One is suicide and one is parasuicide. So suicide is a severe attempt with the intent to die, while a parasuicide is an attempt to seek attention. Now this parasuicide means slashing wrist, okay, or taking a khatnil, or taking something which won't kill them, but they would seek the attention. Now these parasuicides are also very common during adolescence age group. So young girls, young boys, to seek attention, they would cut their wrist. After a breakup, they would try to bang their head. They would try to eat 2-3 tablets of something. This is not with the intent to die. This is just with the intention to seek attention. But as you said, those who are attempting once, they are more likely to attempt again. Or there is a rule of fifth. It is called a rule of fifth. Those who are attempting, there are 20% chances that they would have already attempted before, or they would attempt in the future. That's a 20% risk is always there. So irrespective of suicide or the parasuicide, we have to take them seriously. When it comes to suicide, we can't take it lightly, whether it is attention seeking type of the parasuicide or whether it is a intent to die type of a severe suicidal thoughts.
Thank you, Dr. Sushil. These are really alarming figures, and this is an issue of major concern, really. Dr. RG, sir, I just want to ask you, what is age-wise and sex-wise prevalence of this problem, this suicide?
See, actually, the suicide rate, they are more common between the 15 to 29 years. As all of you know, the 15 to 20 years, it's a limbic system that activates amygdala. They are more active. So you might have seen that these aggressions, violence, and risk-taking behavior, they are more common in the adolescents. So it's a prefrontal cortex which is yet to develop. It's an executive function, and it decides what is right and what is wrong. So this at this age, between 15 to 20 or 22 years, the suicide rates are more common. Apart from this age, like 20 to 27 years, there is a what you call, most of the adolescents, they go for job seeking, and there is some relation issues, marriage, and most of the adolescents, they seek job at other places. So isolation is one of the cause. So these suicide rates, they are more common between the 15 to 29 years. Now it has been seen there is a changing trend in girls. It has been seen that girls, according to NCBR data, 5,600 girls under the age of 80, they died of suicide, and boys, they are about 5,075. This was the statistic that is carried by the National Crime Records Bureau in 2021. So now the trends has been changing. Now the what you call the girls, because the girls, they are emotionally unstable. So there are some what you call the marriage problem, or they are very sensitive. There's some relationship issue. There might be some hormonal changes, or there is a family conflict. So it has been said that if I'm not wrong, Dr. Sushil, you have seen that the suicide rate in girls, they are more common as compared to boys.
Particularly parasuicides are very common among us.
Yeah.
Thank you, Dr. Patil, sir. Now, Dr. Sushil, sometimes we hear that a college student was since long time was putting a status on WhatsApp or Facebook. I am feeling depressed, I am feeling lonely, I am feeling hopeless, and suddenly comes a news that he has committed suicide. So if a person is planning for suicide, does he give some indications or signals before, and how to help him?
Yes, yes. As I said before also, almost all those who die with the suicide, they give some indicators before that. Now, maybe 3, 4 years back, we have written one textbook of cyber psychiatry. So I am and Dr. Bhave, we are editor of that book. So now those indicators are changing over the time. So as I told you before, the depressive equivalents, right? So those depressive equivalents were the old age indicators. So secluded from the families, staying in a single room, trying to spend less time with the other people. So they were the age-old indicators. Now the new indicators are like this. They are modified with the digitalization. So almost all they give such type of the indicators like no meaning in a life, their status would be like this. So very common status which we have collected. So future is dark. Sometimes they put like this. Then sometimes they would put their status absolutely black colored without any wordings on that. Absolutely black type of the status. A person who is very frequently changing his status or the DP now would go absolutely blank. They would try to leave the groups. All if they are into 1, 2, 3, 4 WhatsApp group, they would try to leave the groups. From their voice, from their language or interaction, often a words like there is no meaning in the life. Okay. Linesh sir, in his initial introduction, used the three terminologies: helplessness, hopelessness, and worthlessness. So they go through these ladders. So initial, like there is no one to help me, there is no one to solve my problem, there is no one can take me out of this problem. So these terminologies are going towards the next stage, that is hopelessness. Now there is no hope that I will come out of this problem. There is no hope that I would clear from this problem. And third ladder is worthlessness. I don't find meaning in living life. What is there in the life? Why should I live? What is meaning of everyone of is living in this life? So such words would very often come from their mouth, very often. And around 18 years people, if they are living at home, they would purchase something. They would purchase some tablets, sleeping pills. They would collect some pills around them, or they would try to they would completely stare at the fan. And this is again a very common indicator of the suicide. They would keep on thinking about suicide and look at the fan, ceiling fan, and they would look at the medicines, staring at the medicines continuously. Without any reason, they would arrange for a rope or arrange for a strong cloth which can help them in a hanging. And they would unnecessarily go on a terrace and spend lot of time on the terrace alone. So now, when decreased interaction, decreased socialization is mixed with all these indicators, then we can predict suicide. And as far as the prediction is concerned, we should try to predict, even if it is wrong. We are happy that our prediction should be wrong. But even if we try to predict that this might be a change in his behavior and this might be a suicide indicator, we can prevent many suicides. And as far as the suicide is concerned, even in a severe depression person, he will not try to commit suicide 24 into 7. It is like a impulse. Maybe on this particular day I am getting impulse, but that impulse may not be there on next day or day after tomorrow. So it is like an impulse. If we can help them at that moment of a time, suicide can be prevented. And suicide is such a thing. If we help them in a time, we can definitely prevent suicide. You know, Dr. Ram, on a London bridge, there is one banner. So it is said that those people who are in a thought of suicide, they are more likely to be confused, right? So they have put up a banner there. If you are thinking about suicide, please call on this number. It's a banner. So when someone has a thought of a suicide, he will look at that banner with the hope that they would help him to commit suicide, right? So we are confused. So if such banner is there, very likely we will call them, and that number is because is of a suicide helpline. So there are studies that with that banner they could approach many youngsters who were trying to jump from the London Bridge. So at that moment of time, if we can give them a help, we can prevent, we can postpone, and we can reduce the burden of suicide.
Thank you, Dr. Sushil. And the good message in this is the suicides are preventable.
Absolutely.
And like on London Bridge, there are also suicide helplines in Nagpur of Department of Psychiatry Lata Mangeshkar Hospital with a number of 788806620. A suicide helpline of Department of Psychiatry GMC Nagpur is 0712270157, and suicide helpline number of Department of Psychiatry in AIMS Nagpur is 071223522033. So these are helplines and they will be posted in description of YouTube also. So I hope with this suicide helplines, we will be able to approach so many individuals with suicidal tendencies and help them and prevent suicide, and will make initiative of this World Suicide Prevention Day fulfilled. So next question to Dr. R.G. Patil, sir. Sir, these adolescents are in our follow-up since birth or since their toddlerhood, and they have good rapport with all of us, all of pediatricians. So, sir, what is role of pediatricians in suicide prevention of adolescents?
It's a very important topic, and role of pediatrician is very important. As all of you know, we are treating the what you call the patient as a child, right from the birth to the adolescent. So the treating pediatrician knows his physical, emotional factor. Not only this physical, emotional factor, he also knows the parents and relatives also. So most of the these pediatric patients, they are very comfortable with the treating pediatricians. And second is that we want to detect the suicide or suicidal tendencies in adolescents. So history is very important. So we go by the social history like HEADS, HEAD is there in a home environment? Is there any problem in the home? Then education, is there any problem in the school? Eating habits, then activities, suicidal tendencies, sexuality, and safety. So as rightly said by Dr. Gawande sir, we should not ask the adolescent, are you going for the suicide? Are you committing the suicide? So in other way, there are some questions. Are you feeling how you are feeling? Where is there is a boredom, or is there any are there any pleasurable moments in your life? So one can ask the history. Secondly, there is a one what you call the American Association of Suicide has suggested some warning signs. That is path war. This is mnemonics. So we can go by these mnemonics by asking the question to the adolescent. Then there are some screening tools for the adolescents, like what you call the simple questions for the suicide various tools there is a Colombic suicide screening tool to distinguish between the suicide ideation and suicidal behavior, ask suicidal screening questions, and assessment tools for identification to rule out the underlying mental health problem. So in this way, we can at least identify the adolescents who are committing suicide. And again, the role of pediatrician is very important in the school health problem. And already we have launched last year a different program. We are going to the schools and we are forming the teenage club there. And what are the added, because generally these adolescents, they don't come directly to the pediatrician or the health professional. So what we are doing, we are going to the school and we are forming the teen club, and we are just identifying the adolescent who is having the abnormal behavior, as rightly said by Sushil Gawande sir, and whether he's taking the part in the activity, whether he's interested in the school. So these students are to be identified and they are reported to the teacher, and in teacher will in turn report to the treating pediatrician. So we are identifying the suicide or parasuicide or suicide, those who are committing suicide in the schools. So in this way, we can just lessen the burden of suicide. So in this way, the role of pediatrician is very important, and also creating awareness through the media.
Thank you, sir. Now, next question to our president, Dr. Linesh sir. A patient, an adolescent comes to us with suicidal tendencies or some depressive illness. Sir, at what point of time we should refer that adolescent to psychiatrist? Dr. Linesh sir.
Thank you. Very good question. I take this opportunity to describe when a person or patient should be referred. If I am a pediatrician, I have to refer a patient whenever I find any kind of suicidal behavior, which includes suicidal ideation, suicidal attempt, or self-harm, or even any intention of harming other people. I will not only refer him, but I will have to put down this referral in my notes that I have referred this patient for the psychiatric help. That is very important part of maintaining our papers properly. But I also take this opportunity to elaborate on when to refer. For general public, any negative symptom which lasts more than 2 weeks probably needs expert advice, and such patient or such person should be referred by general public, whether they are parents of that adolescent or friend or anybody, to at least a practitioner who is ideally to a psychologist, adolescent counselor, or psychiatrist. When such patient or person comes to a busy OPD of general pediatrician or physician, a general pediatrician and physician, I advise that he should use some sort of teen screen questionnaire, at least to pick up the patients or persons who need psychological help. And if I am adolescent counselor, then I am going to refer this patient whenever he has suicidal behavior or any kind of suicidal ideation, attempt, or self-harm, or any other. I will also have to refer this patient to psychiatrist in case of severe depression or when there is substance abuse or decline in functionality. When the functionality is constantly declining, I would have to refer this patient to the psychiatrist. Thank you.
Thank you, Dr. Linesh sir. And as you rightly mentioned, documentation is also essential while referring a patient to psychiatrist. So next question to our
Bharat.
Yes, sir.
Sorry to interrupt you. I was saying because most of the our adolescents, they are not comfortable or they resist going to the psychiatrist. So generally what we do, we just call a psychiatrist to our OPD.
Okay.
So it is what they say, because when you refer the patient to the psychiatrist, they will take time, 15 or 20 or a month, they will not go. So I think generally Dr. Sushil is also coming to our hospital. So what we do, we just call Sushil to our hospital because they are not comfortable their OPD.
Yes, sir.
Thanks. Thank you. Sir, next question to Dr. Kamlakar, sir, our senior. Sir, students remain in school for almost 6 to 7 hours and they are in contact with teachers. So, is there any role of teachers in identification of suicidal tendencies and suicide prevention?
Yes, sir. Very important thing is that in shaping the student's life, as parents are important, the teachers are very important because the child is in the school for around, say, 8 hours per day. And I can say that the teachers are actually playing the role of a gatekeeper. And in United States of America, a study was conducted where they have given the name as a gatekeeper model. And that what they have seen that these teachers were trained and training of trainers was done. And then the teachers, as they are observing the students' daily behavior and the behavioral changes, as the respected Dr. Sushil Gawande sir has said, that the depressive equivalence, that suicidal behavior tendencies are there, and the teacher is at the best place to immediately identify the change in behavior of the student. So if the student is not attending the class properly, if he's not keeping him well, and many times what students do, as rightly Gawande sir has told, that he keeps his all the social media blank. These students, they wear black clothes and they come to the school. That was observed. Whenever there is a cultural event and when the uniform is not compulsory at that particular day, these students, they will wear complete black dress and they will come to the school. They will not mix with the students, and there is an academic imbalance in their performance. When the student was achieving 90%, now he's coming to 70%, 50%. I have many students because I was a teacher like that. I will tell you one story if time permits. So there, what the teacher can do, the teacher can immediately identify. And now, as the age of the depressive equivalence is decreasing, as there is a maturity coming to the adolescents, we can see that 11-year student, 12-year student, they are also having the suicidal ideation. So what happens in middle school or high school people? In early age group before 10 years, only one teacher is there teaching entire 6 hours. But in high school or middle school, what happens? After every 1 hour, a different teacher is coming to the class. So these teachers can discuss with each other in the staff room, having full confidentiality, and they can have a discussion that whether this particular student is behaving some abnormally, is he behaving similarly in your class, or have you observed anything like that? Yes, they can discuss with that. Then they can create a supportive environment for these students and have an open communication with the students. Also, many students are bullied in the class. Either they are bullied or they are acting as a bully. So these teachers can immediately identify and prevent the bully, because bullying is very important factor for this suicidal ideation, and they can commit the suicide because of these severe bullying in the schools. And schools is a very common place where the bullying is taking. Now they can encourage the students to talk more than to give the lectures. So a teacher can encourage a student to talk more and express them. They can educate the students, and these teachers can have a particular section of a time, that's say 15 minutes each day or something like that, where they can discuss the different mental health problems with students openly, not for a particular student, so that the going to counselor of the school is not a taboo. as Dr. R.G. Patil has rightly said, that if I refer the person to a counselor or to a psychiatrist, then there is a taboo that why I am referred to counselor. So the teacher nowadays, what they are doing, that in every school there is a counselor. And I think Abhijit Bhardwaj was also going to one of the school as a counselor in Somulwa school. So I would suggest that each and every student should go to a counselor for some time, 5 minutes or 2 minutes, like that. Not a particular student, identify a student and then refer to a counselor, then there is a taboo. So if
Yes.
every student is going to a counselor, so there won't be a taboo and they won't feel anything in discussing the mental issue problems with the teachers. So that is what, and they can have an early intervention and encourage in seeking help of mental problems. So that is very important. And again, now the importance of yoga. Yoga, as Gawande sir has told, that 5-HIAA, that is 5-hydroxyindole acetic acid, is a precursor of serotonin. So I will ask one question. Actually, I'm not supposed to ask, but still Gawande sir can answer that whether, because it's an open discussion. So if you perform yoga or some meditation or some concentration technique, is this precursor will go increasing, and so that the serotonin level will go up and the adrenaline level come down, so that the student can prevent the suicidal ideation. And before, just a minute, sir, just a minute. And I will tell you one story, because I was a teacher. I was teaching in one of the college. I saw one student was there. I cannot reveal his identity. He was attending my class daily, but one day he didn't. And he was just sitting in front of the office. So when I came from the lecture back, I asked him, why you have not attended the class? So he said, sir, I'm not feeling well. I'm having fever. Please give me one tablet of crocin if you are having. So see, I'm not having the tablet, but just I when passed from him, I smelled something abnormal. So I asked him, please show me your tongue. So that tongue was entirely blue, sir. So I was horrified. I slapped him, actually. Finally, a student, see, in the college, I slapped him. That was not permitted, but I slapped him because I was very anxious. And then I smelled and I found that there was an organophosphorus compound which he has consumed. I immediately took him, caught his collar, went to my car, put him inside the car, and went back to Lata Mangeshkar hospital immediately, because I was in Hingna at that time. And my college was Datta Mege College. So I took him to Hingna, and fortunately, my friend was there in casualty. His name Dr. Patil. He was doing DM cardiology at that time. So I said, please come here and help me. He immediately came and saw him, put the Riles tube and all that we did. He went into coma, was there in ICU for 15 days, went into renal failure, but ultimately he came out. So I could save his life. So that was the story. Thank you very much for giving me the opportunity, to all the panelists and the distinguished guests here. Dr. Gawande, I could listen him. Thank you, sir.
Thank you, sir. Thank you so
Thank
much.
you. Thank you, Dr. Kamlakar, sir. An ideal teacher is really very essential in shaping the life of future. It's a fact. Sir has just told about his student who, with the fear of failure, tried suicide attempt. Dr. Sushil, I just want to ask you, uh, will you please guide us and our audience how to face failures? What are coping mechanisms of stress management? What are different models of stress management, and what are different ways of coping skills and facing failures?
Yes, yes. Dr. Ram, I would, because it's a very vast topic, we would just cover under certain, as brief as possible. To ask to mention the question of Kamlakar sir. First of all, sir, thank you so much. You have highlighted the situation so briefly and so concisely that everybody is now able to visualize the moment someone commits suicide and what should be our action. So I would say the earlier doctors were more clinical, and they would smell and diagnose, they would see and diagnose, they would hear the sound of tap and diagnose. And we are more trained in the era of investigations, and had we been there, we would have missed this case. So thank you so much. Sir, as far as the yoga meditation part is concerned, there are two things. There is always a state of hypercortisolemia among those who are under stress, be it a stress of a depression or be it a stress of any external factors. So if we scientifically read about the yoga meditations and its relation to the serotonin, it is mostly via cortisol. So if we practice it, it reduces the level of cortisol. And when there is a reduction in the level of the cortisol, automatically there is a surge of serotonin. So because of the surge in the serotonin, that is the way it helps to lift our mood. And now fracture of bone is visible. But if someone stays in a state of hypercortisolemia for 6 months, it is not visible, but it is equally damaging to the all neurotransmitters of the body, all neurotransmitters of the brain. So when it is unseen, it doesn't mean that it's not hampering. And yoga meditation has a very, very beautiful role in prevention of all these matters. So now, maybe Ram, around 7-8 years back, we had conducted, this is my study, it is my and Dr. Abhijit Bhai, it is published in a index journal, resilience among first MBBS students. So we have compared that resilience. So one scale of resilience is there. And we have realized that on many components of that resilience scale, our youngsters are falling short of that. And this difference as compared to the earlier generation people and the newly admitted students, if you find that it's a statistically significant difference. So one resilience skill could be how to face the failure. One resilience skill is to how to get mixed with the people. One resilience skill is if you are a scapegoat of someone, how to seek help. One resilience skill means if you are short of your expectation, how to motivate yourself. So all these were the factors in the resilience skill. And these many youngsters, they were falling short of this resilience skill. So earlier, maybe this question was of academic purpose 30 years back, but it is of a clinical purpose in 2024. So we have to teach our children resilience. Resilience is ability to bounce back, and it will not come in a day because it's a matter which should be instilled during the phase of upbringing. So now I'll tell you, we have explained our children about the Manu Bhaker and all those who scored gold medals or the silver medal and the bronze medal in the Olympics. What is more important to tell is to tell them about the Paralympics. Okay, how the athletes who are disabled, they are able to overcome their disability and score more. Okay, such stories are so important for our children through their childhood, that failure is there, but one can bounce back. A person who has a single limb, if he can win the medal in the badminton, okay, so our problems are a very short problem. So such stories means now with the conscious thoughts we need to tell them since the childhood. See, Abraham Lincoln, when he started his political career, so for 17 long years, he failed in each election. In between, he was depressed, he was admitted, he was under depression for a 6-month time. For 17 years continuously, there was political debacle. Always he lost. But at the end of 17 years, Lincoln, he won the election and he became a president of United States of America. So now this life of the Lincoln is famous with it is called a theory of failure, Lincoln's theory of failure. Now, take an example of Sudha Chandran at the 17 years of age, tender age, when her career was blossoming. She was a classical Bharatnatyam dancer, and her career was about to blossom. She suffered an accident at Tiruchirappalli, and she lost her limb. That time, Jaipur limb was available, and she was given with the Jaipur limb. And after 3 years of continuous practice, at the age of 21, she started her world tour of her dancing. And the Nache Mayuri is a movie based upon the life of the Sudha Chandra. So many such examples we need to instill from a very, very early childhood among the children, that disability or any failure is just a matter we can overcome. That's one thing. Second, sports is a very important activity where every day we learn to face the failure and enjoy the success. Every day. there is no other best way to learn how to sustain the failure than the sports. So if we are allowing our children to play, okay, if they are playing cricket, in a day they will lose, another day they will win. If they are playing badminton, on 2 sets they will win, on third set they will lose. So sport is such an activity where we can learn to digest the failure. Third is important is a group activity. If we make our children involved into the group activity, so if in a group, if they are doing some activities and if some problems are there, so they talk to each other and solve the problems. This talking to each other is basically a step of a problem solving. So when someone has a problem, we should seek a help, and this only can be learned when there is a group activity, otherwise it cannot be learned. So these are the very simple steps. Another is called as a cognitive model of the resilience. So in a cognitive model of the resilience, there is a first model that is called a process outcome model. In this process outcome model, though the word is very heavy, the understanding is very simple. For our children and the youngster, we should always guide them to concentrate on the process and not on the outcome. So if they are preparing for their exam, every now and then we need to guide them. They just concentrate on the process. Just do best whatever possible for you. Don't count the outcome. Don't concentrate on the outcome. So this is called as process outcome model. Now, whenever your child has good marks or bad marks, after that, if we concentrate on the process, you have done hard work, your process we have seen, you good in the process of the resilience building. Third model is called a here model, or here we so if I'm failing to secure marks in a 10th standard, it's a part of life. It's not an entire life. If I am failing to score in some competitive exam, it's not entire life. It's a part of life. So it is called as here and now model or a gestalt model. We should help them to learn that this is not an entire life. This is a part of life. Third important is a resilience building. If we compete with ourselves, that gives us a more resilience. If we compete with the others, that reduces our resilience. So teaching that whenever our children are preparing for something, are there, always teach them that your competitor is yourself. Compete with yourself. Earlier you were performing this much, now you are able to perform this. We are happy with that. So if we teach them to compete with the rest of the world, or if we teach them to compete with their friends, then that adds to a lot of anxiety, and it reduces the resilience. If they are taught to believe that compare with yourself, earlier you were till this stage, now you have to go ahead of this stage. That is it. Last, in a cognitive model is a model called a ventilation. Ventilation among the psychotherapy, I would say the most effective psychotherapy is ventilation. We need to teach them, we ingrain in their mind that whenever they are into some problem, please talk about that problem. Whenever if silliest problem is also there, please talk about that problem. If we instill them the importance of the ventilation, catharsis, if they talk about the problem, that habit goes on a long run. If they don't have that habit, then all of a sudden they will not ventilate. So telling them that if you have a problem, talk about that. Talk to me, talk to your father, talk to your sister, talk to your teacher. But talking, that is very, very important. So this would go on long, but again to concise during the childhood period, if we instill all these models, I told you about the telling them about the stories, involving them in the sports, involving them in a problem solving activities or a group activity, process outcome model, here and now gestalt model, self comparing with the self and not with the others, and ventilation. So I find these 4 or 5 models are very good to develop a good resilience among our children.
Thank you, Dr. Sushil. Dr. Sushil, will you please explain in very brief about role of pharmacotherapy?
Once someone comes with the suicidal attempt, our first purpose is to identify whether it is a suicide or a para-suicide. Now, if it is a para-suicide, that my mother did not offer me coffee on that day, or my boyfriend, he didn't pick up my call and that's why I cut my wrist. Okay. So if it is to seek attention, we ask them a question. Okay, and again, asking about the suicide has a very particular question. Okay, particular question. So we don't ask adolescents or youngsters, do you have a thoughts of suicide? No, we don't ask like this. Our question is always, do you find life worthless? That's the very common. म्हणजे जीवनात अर्थ नाहीये असं वाटतं का? ओके, किंवा जीवन संपून जावं असं वाटतं का? सो डू यू फील लाईफ इज नॉट वर्थलेस? जीवनात अर्थ नाहीये का आणि जीवन संपून जावं असं वाटतं का? दीज आर द युज्युअल क्वेश्चन्स वी आस्क. They are less stigmatizing. They are less, I would say, not making them apprehended. So such type of questions. So we divide into suicide and the para-suicide. If it is a para-suicide, Dr. Ram, means if it is attention, no, sir, I don't want to die. But he did not pick up my call. That's why I attempted. Now I taught him a lesson. Now he will not miss my call. He will call me back. Now this is an attention-seeking type of the suicidal attempt. Here, a role of pharmacotherapy can be deferred, and the role of counseling is in the first step. Now, when it is second part, that's a serious attempt, intention to die. No, doctor, I thought I should die. Okay, my intention was to finish my life. Then it is considered as a serious suicidal attempt. And here, and serious suicidal attempts are again can be compared with the attempt. Means if you are taking 2 tablets, right? Of something, of multivitamin, or if you are putting a razor on your finger, okay, that can also tell you whether it is a severe suicidal attempt or whether it is a attention seeking. So when it is attention seeking counseling, and when it is a severe suicidal attempt, we don't wait. If he falls into a category of a major depression, usually it's a major depression, we start with the treatment immediately. And counseling will go hand in hand, but we can't wait because suicide is an emergency. And as I said, it's something to do with the neurotransmitters. Okay, neurotransmitters. So we need to replenish those neurotransmitters. We can't wait. Immediately we need to start them on a pharmacotherapy. There is a concept of called as a paradoxical suicide. Means after starting on a pharmacotherapy, some children, they can impulsively gain energy to think about the suicide. See, after giving SSRI medications, the antidepressant effect or the effect on a sadness of mood will start after 2 to 3 weeks. But energy, okay, that we feel energetic, this effect might start after 1 week. So during this, after starting treatment, this period of second week is very important. In a second week, they get some energy, but their mood is still sad. So they get more energized to even succeed in suicide. So that is called as a paradoxical suicide. So we start them on a treatment. We make the family members aware about all this, that we need a continuous attention to this child for 3 to 4 weeks. And if it is severe enough, if there is a less family support, we don't hesitate to admit them. Because when we admit them, there is a continuous surveillance. If they are treated in the family, we make the family members to stay with them continuously. Keep the sharp objects away from that person. So keep everything, Shuri hai, Lakshman Rekha hai, and all those insecticides in the lock, and do not leave that person all alone. So we immediately consider all those steps because they are the life-saving type of the steps.
Thank you, Dr. Sushil. Very nicely explained. Now, at the end, I request Dr. Kamlakar sir to summarize what are the strategies of suicide prevention. Dr. Kamlakar sir.
As
Yes.
rightly said by all the honorable speakers today, that to prevent suicide, as suicides are preventable. So that is very important for the society. And we all as doctors, the parents and the teachers, we must take the responsibility to prevent suicide. It's very sad that we have to discuss about suicides. It's very sad, I feel about that, because they are easily preventable in our society. For prevention, we must have a good education policy from the government side also. and that must be implemented in different schools so that every child is open to discuss with his parents, with his peers, and with his teachers. Whenever we should teach them that whenever they feel something abnormal in their life, they must seek support from some person who they trust, a trustworthy adult to whom he can express himself. Secondly, I can also say that the family where there are many issues like broken families, divorced parents, drug abuse in the families, the father is not supportive, economical problems. So all these social issues are there which are causing problems for this. So it's not a one day thing where we can just talk and prevent suicide. It's very difficult. And for that, the efforts must be done at all the levels, at the socio-economic level, at the school level, at the college level, at the, you can say, even in the corporate sectors. Though we are talking about adolescent thing, but adults are also committing suicide because of the breakups and all that. So we have to target by performing all these activities. There is, I always tell in my talk that one phone call to a person when he is in distress, actually at that point of time, identify. Second, 15 minutes of talk in a school. So we should arrange the activities in different schools. And I always congratulate the management of different schools who arrange the talks for the psychiatrist or talk or the adolescent counselors talk in the school for the students. And 1 hour spare everybody to visit the person in distress whenever you get time. So that one meeting with that person, 15 minutes of talk in a school, and a one phone call can save the person's life. So many things that we can do. And as a pediatricians, I always tell that when you are a busy pediatrician in your OPD, just treating sardi khasi is not important. That when the person comes to you, you take the opportunity to talk with him when the child is in a 12 years or 13 years old. ती कोणत्या वर्गात शिकतो रे बाबा तू काय करतो 2-3 गोष्टी त्याच्याशी बोला जस्ट टॉक विथ हिम अँड आस्क हिम टू ओपन अप just you will know okay, what type of mental status he is having. So we don't talk like that. We just the person comes to our OPD, we just treat his physical ailment, we treat his infections, and the person goes. So I request all the pediatricians that whenever the child comes to your clinic, please take the opportunity to talk with him for 2 minutes. That is very important. So there are so many things which cannot be narrated in this thing. I think Kotwal sir will be the best person to do that. Thank you very much, sir.
Thank you, Dr. Kamlakar sir. We welcome Dr. Nishikant Kotwal sir, who is chairperson of Maharashtra Adolescent Health Academy, our teacher, guide, and mentor. I request Dr. Kotwal sir, with so many years of experience, of practice, knowledge, sir, will you please throw some light on strategies of suicide prevention, and will you please guide our viewers and our adolescents about suicide prevention? Dr. Kotwal sir, please.
Thank you very much for calling me. And I'm not an expert. You already have Dr. Gawande as an expert on this in this particular topic and subject also. Can you hear me all?
Yes,
Yes, sir.
Okay. We have to first know what are the risk factors for suicides in India. The basic reasons are when it is childhood, it is academic failure or disrupted education. That is the commonest thing in childhood. And when we go to adolescent, the major cause of why people go for suicide is abuse, trauma, bullying, stigma, and minority stress. These are all statistical things which I'm trying to tell you. Then another thing is, we were talking about, Dr. Gawande was talking about, there is another thing, I don't know whether I was not here, the acute suicide risk. The acute suicide risk, there is an typical mnemonic, ease path warm. I think everybody is aware. Have you talked about ease path warm?
Yes, sir. Yes, sir.
Okay. So people have already said about is the path warm. So ideation, substance abuse, purposelessness, anxiety, hopelessness, withdrawal, anger, restless, and mood changes. Another thing which we all pediatricians should know, I think Dr. Gawande would agree, we really will not be able to prevent totally suicides, but
Yes.
acute suicides can be really prevented. Because those who are having psychotic diseases, those are the people, it will be very difficult to prevent. Rest all, which are because of some reason or the other that you are tempted to do it, can be definitely stopped. And the ask scale, I think that everybody knows NIH scale, that is suicide screening questions. There are only 4 or 5 questions which are to be asked, and whatever grading is there, you know what is the risk of suicide in that particular patient. The risk assessment is very important, whether we have a low risk, moderate risk, or severe risk. And I think you must have covered that, because low risk is it's a thought process. Moderate risk is thoughts with intent, means you have a thinking of planning it. Severe risk is you have a plan. So the warning signs of suicide, yeah, whenever they are there, then multiple risk factors, past history of suicide attempt, self-harm, psychosis, substance abuse, severe mental disorder, refusal to follow treatment plan is, I think, should be taken as one of the sign of severe depression, because why patient is not coming up to take treatment? Why he feels that it is all hopeless? So unless and until he feels it is hopeless, he will not stop treatment. Other teamwork. So it has to be with everybody, with school and other things. And after the attempt, so I think Dr. Gawande, post suicide attempt is the crucial period for
Yes.
preventing suicide.
Yes, sir. Absolutely.
Thank you very much.
Can I add something?
Sure.
Yes.
Ram?
Yes, Sushil. Yes.
As all of you know, what you called, we are suffering from many mental health problem. I think there is a shortage of mental health professional. I think India is
Absolutely.
87%, if I'm not wrong.
Yes, sir.
Gawande.
Yes,
There is
sir.
a shortage of, so it's only the preventive measures we can conduct, how to prevent the suicide and other para suicide rates. Thank you.
Thank you, sir. Thank you all panelists for their valuable time. Now, at the end of this panel discussion, I request our dynamic secretary, Dr. Dinesh Saroj, for vote of thanks. Dr. Dinesh Saroj.
Yes, sir. Thank you all panelists who have joined us in this vital effort today for suicide prevention. At the outset, I would like to thank Dr. R.N. Sharma, sir, for blessing us today. Thanks to Dr. Nishikant Kotwal, sir, for being the constant source of inspiration for all of us and guidance for conducting this activity. Thank you, Dr. Sushil Gawande, sir, our faculty today, for enlightening us on this important topic with your valuable insights. Your guidance on indicators of preventing suicide is very well taken. Dr. R.J. Patil, sir, thank you very much for devoting your valuable time today and blessing us with your words of wisdom. The stats you mentioned were really alarming, and definitely this will help us in formulating plans and executing the prevention measures. Thank you, Dr. Kamlakar Deoghare, sir. You very rightly highlighted the role of teachers in preventing the suicide. Thank you, Dr. Abhijit Bhardwaj, sir, as you briefed us about pathophysiology and predisposing factors for suicide. Thanks to Dr. Linesh Yawalkar, sir. Your presence and insightful discussion today will help break the silence, offering hope and spreading the awareness. Thank you, Dr. Ram Bharat, sir, for finding out time from his very busy schedule, taking the lead from the front, and taking all efforts in planning, coordination, and ensuring smooth moderation of today's activity.
Thank you.
Sir, your courage to engage, support, and be present will definitely make a difference. Thank you all the participants for your valuable presence today. Finally, I would like to say that every voice matters, every action counts, and by standing together, we can help save lives. Let's continue to be beacons of hope for those who need it the most. On behalf of Adolescent Health Academy Nagpur and Maharashtra AHE, I would like to thank all for your compassion and commitment. I would also like to request our viewers to forward this video to as many as possible with the hope that it will reach the right person in the right time. Thank you. Over to Dr. Ram sir. Thank you, sir.
Thank you, Dr. Dinesh.
राम सर.
Yes, sir.
चॅट मध्ये एक कमेंट आलेला आहे की we have a comment in our chat box. While counseling,
Yes, sir.
should we say that you have no right to take we have no right to take our lives? गावंडे सर, आपण असं म्हणू शकतो का पेशंटला की तुला तुझं लाईफ घ्यायची राईट नाही आहे?
See, if we are too advisory during that critical moment now, it doesn't help. Okay. Expressing as much empathy as possible, I can understand. Okay, I can understand your state. Okay, I am with you. Okay, and we are with you. Such things helps more. Okay. Now you have no right to take your life. Okay, suicide is a bad thing to be done. If you are doing this advisory type of the comments, you are making that person away from you. He will not connect to you. So the first step in this critical moment is empathy. Okay, touching the shoulder that I am with you. Don't worry, I am with you. I can understand the things you are going through. I can understand the pain you are suffering. If that is there, then he will open. But if we are in a typical doctor advisory mode at that moment of time, they will go away from us. So anything, I know you have.
I think you are absolutely right, because that is the time we have to be with him.
Yes.
And not being a dictator that this what you have done is very wrong.
Yes.
Yes. Yes, sir. Absolutely.
Unless we are empathetic to him. And then the next step would be a SWOT test, I would say, that tell him that you have lot many strengths, lot many positive things, that life is not so bad for you that you should end. There is always a way, there is always a light at the end of the tunnel, and you are not placed very badly. You can do it.
Simple steps are: first is a crisis interventions or a catharsis, ventilation, making him as much able to talk. That is first thing. After second, third visit, that would be supportive psychotherapy. I am with you, I am with you, I am with you. And then a cognitive behavioral therapy will come. So trying to teach him, trying to change his thoughts would come later. So a suicidal attempt first would be just crisis intervention, making him talk about this, making him feel the empathy. After next session and next session, just only supportive psychotherapy. I'm there, we are there, we can together change. And then your thinking is wrong, we can correct it, would come later. So these are the steps of usual psychotherapy with any child with suicide.
Thank you. Thank you very much. Excellent advice for us. And this point was very well brought forward to our notice by Dr. Parimala, and in chat box itself, Dr. Madhushri Deshpande has answered it. We should show concern with empathy. So it was a nice answer. Thank you. Dr. Aryan Sharma, sir, do you want to comment something?
Thank you very much for the excellent this panel discussion. And I really thanks moderator Dr. Ram Bharat and all panelists and our own RG sir, Linesh, Dr. Sushil, for giving excellent input for the resilience building. Thank you, sir. Thank you very much. And Kotwal sir, thanks for your expert comments. So हमारे यहाँ एक कहावत है, क्षण भर का टालना 1000 वर्ष की आयु बढ़ाता है. So that is the momentary movement anyone can suicide. So we have to prevent that movement. Number one. Number two, resilience building, as Dr. Sushil said, and ventilation is very important. And talk, as rightly said. So this is our duty, and as a stakeholders and teachers and as a parents first, to prevent the suicidal and save precious human life. This is very precious human life. Thank you for organizing this excellent and wonderful talk session. Thank you very much, sir, and inviting me. Thank you.
Thank you, sir. It was wonderfully overwhelming to have esteemed participants like you, Dr. Parimala, Dr. Shubha Badami, Dr. N.N. Joshi, Dr. Madhushri Deshpande, Rushali Raje, and we are equally overwhelmed with the very warm response when we asked for link to Central AHA. So I must also thank Dr. Geeta Patil Madam, Dr. Prakashvir Arya sir, and Dr. Aryan Sharma sir. Thank you very much. Here we stop our recording. Thank you.
Thank you, sir.